Hello, my name is Michelle Petri, and this topic is life or organ-threatening lupus. What to do? Is there anything new? And I'm going to concentrate on two abstracts from the ACR meeting. Now, first, let's put this in perspective. There's lots of life-threatening or organ-threatening lupus out there. And of course, we have approaches. Now, I put SLE with catastrophic antiphospholipid syndrome high up there because, it can have as high as a 50% mortality. And I approach that with rituximab. I would love to use eculizumab if only I could get it approved in time to help the patient. But there's so many other things. There's rapidly progressive GN, diffuse alveolar hemorrhage, myocarditis, recurrent lupus enteritis, really severe thrombocytopenia. And for many of these, I'm going to respond with rituximab or cyclophosphamide. But I have patients who fail rituximab or cyclophosphamide. And again, we've tried to find novel ways of treating them. For a long time at Hopkins, we were doing high-dose cyclophosphamide, without stem cell rescue, although other centers did it with stem cell rescue. We haven't even had two of my patients who had a haploidentical bone marrow transplant. One went into a long-term remission. But now, the hot thing is CAR T. Now, CAR T has lots of risks, and I don't want to minimize, of course, rituximab and cyclophosphamide have risks as well. CAR T risks, though, are not familiar to rheumatologists, and so they include cytokine release syndrome, CAR T cell-related encephalopathy, ICANS, just another term for the neurologic problems with CAR T, the lymphodepleting regimens, the fludarabine and cyclophosphamide have their own toxicity. And then, of course, both short-term and long-term, we have to be worried about infections and hypogammaglobulinemia. And finally, of course, are the costs, right? We're talking about almost $500,000 per patient. That would pay for a lot of rituximab and cyclophosphamide. So how did this get so much attention? It started with this N of 1 study that was published in the New England Journal of Medicine, so we all saw it. And this was obviously a multi-system active lupus patient. And you can see within 1 month of getting the CAR T, all the organs calmed down, and this patient was just left with some anti-DNA. So this patient had a good short-term outcome. Long-term? Big question mark, right? So now presented at this meeting, but also at EULAR and also now published, is the 5-patient series. In the early follow-up, these 5 patients met the lupus low disease activity state and DORIS remission state, although one patient had a SLE day of 2, which means to me that they didn't meet DORIS remission. Now, the B cells do reappear at day 100, and these good outcomes were maintained through day 100. The safety was remarkably good. There was mild cytokine release syndrome in just 3. I must say, maybe they were just really very lucky, because when you give CAR T to larger numbers, I'm afraid we're going to see much more toxicity. But the big question is, where's the long-term follow-up? They haven't had a chance to figure that out. And you should ask yourself, what would you expect from something like this? What do you want the remission rate to be at 5 years? Should it be, like way over 50% to justify something like this? So now I want to turn to APS. And this is a laboratory study, not a patient study. And it comes from the group of Max Koenig here at Hopkins. And now instead of CAR T, he's talking about chimeric autoantigen T cell receptor. What does this mean? We're not going to get rid of all the CD19 cells. This is going to be targeted just to those that make anti-beta 2 glycoprotein 1. So he has reprogrammed T cells at the laboratory bench to be selective. And he's proven they're selective once he does this. He's only getting the anti-beta 2 B cells, and then, there's nothing to produce beta 2 GP1. So he calls this precision cellular immunotherapy. And remember, the strong rationale here is to avoid depleting all B cells to limit the infection risk, because people with lupus, one of their major causes of death is infection. So he's shown that at least on the laboratory bench, he can treat autoimmunity without impairing the protective part of the immune system. Now, of course, there are limitations, aren't there? We have to prove that this will work in vivo. And in a patient series, not only must it prevent thrombosis, but it must eliminate the need for anticoagulation. Because in your APS patients and mine, not only do we have the problem of recurrent thrombosis, but we have the problem that these patients really need warfarin. The DOAC trials have shown that DOACs are inferior to warfarin, and they are at risk of bleeding. So to conclude, CAR T is hot right now, but I've been around so long, I've seen lots of other things be hot for lupus and then not pan out. And I would include total nodal irradiation, but even the work that I did on high-dose cyclophosphamide, because when we had the control group of NIH cyclophosphamide with long-term follow-up, both groups were the same. But I'm very enthusiastic about precision cellular immunotherapy, right? For other diseases as well, where there's just, one thing that went wrong, whether that's, hyperthyroidism or myasthenia gravis or pemphigus, but for things like antiphospholipid syndrome, wow. Now, maybe lupus is too complicated for precision cellular immunotherapy. And if that's the case, then remember, I'm not going to be enthusiastic about CAR T until I see the 5-year durability. Thank you for listening. Please remember that Room Now has been there for you at the ACR meeting, but it's going to be there for you every single week.